Weight loss is often viewed through a lens of health and discipline, celebrated as a sign of progress or self-control. But in the context of cancer, especially in advanced stages, weight loss can take on a very different and dangerous meaning. Cancer cachexia, a complex syndrome characterized by involuntary weight loss, muscle wasting, fatigue, and metabolic disturbance, is not just a side effect of illness. It is a major driver of treatment failure, poor quality of life, and premature death. Unlike typical dieting or calorie restriction, cachexia is not reversible by simply eating more. And yet, it remains widely misunderstood, underrecognized, and undertreated, even in clinical settings where early nutritional intervention could make a meaningful difference. Cachexia affects up to 80% of patients with advanced cancer, particularly those with gastrointestinal, pancreatic, lung, and head and neck malignancies. It is marked not just by the loss of fat, but by the breakdown of skeletal muscle, even when caloric intake appears sufficient. This muscle loss is driven by systemic inflammation, tumor-induced metabolic changes, and a cascade of hormonal and cytokine signals that disrupt normal energy balance. As the body enters a hypermetabolic state, it burns through resources at an unsustainable rate, making recovery incredibly difficult. The result is weakness, impaired immunity, reduced tolerance to chemotherapy or radiation, and an elevated risk of complications from infections or surgery. What makes cancer cachexia especially troubling is that it is often mistaken for ordinary weight loss, or worse, seen as a positive sign. Patients may be praised for losing weight, without acknowledgement of the underlying pathology. In some cases, especially in overweight or obese individuals, unintentional weight loss may even be interpreted as beneficial. This misconception can delay diagnosis and lead to missed opportunities for early nutritional support, which becomes harder to implement as the disease progresses and the body enters a state of irreversible catabolism. Malnutrition in cancer is not just about aesthetics or body image, it is a clinical emergency. Even a modest loss of lean body mass can impair respiratory function, prolong hospital stays, and reduce survival rates. And yet, nutritional assessment is rarely prioritized in oncology care. Many patients are not referred to a dietitian until they've lost a significant percentage of their body weight or are already showing signs of severe debility. By that point, interventions are less likely to succeed, and options may be limited to palliative support. Early, proactive nutritional care is crucial. This includes not only monitoring weight and body composition, but also tracking appetite changes, food intake, and functional measures like grip strength or fatigue levels. Nutritional counseling should begin at diagnosis, not after weight loss becomes apparent. In some cases, oral nutritional supplements, appetite stimulants, or medications like omega-3 fatty acids or anti-inflammatory agents may be appropriate. For others, more aggressive strategies such as enteral, tube, feeding, or parenteral for nutrition may be necessary, especially when gastrointestinal function is impaired. The goal is not simply to add calories, but to preserve muscle mass, sustain treatment tolerance, and maintain dignity and energy for as long as possible. The psychological toll of cachexia should not be overlooked either. Watching the body waste away despite efforts to eat can be profoundly distressing for both patients and their families. This sense of helplessness can erode morale, contribute to depression, and strain relationships around food. Families may feel frustrated or guilty when attempts to feed a loved one are unsuccessful. Patients may feel pressured to eat when they're nauseated, in pain, or deeply fatigued. Navigating these dynamics requires compassion, honesty, and guidance grounded in medical understanding, not cultural expectations about food and weight. Importantly, not all weight loss in cancer is due to cachexia. Some patients may lose weight intentionally in early stages to improve overall metabolic health or reduce comorbidities, particularly in breast or prostate cancer. In such cases, structured dietary interventions with professional oversight can be beneficial. But distinguishing between controlled, intentional weight loss and pathological wasting is critical. The latter demands urgent clinical attention, not celebration. Ultimately, the myth that weight loss is always a good thing needs to be dismantled, especially in cancer care. Cancer cachexia is not a matter of willpower or dietary habits. It is a metabolic crisis. Recognizing it early, intervening aggressively, and treating nutrition as a vital part of oncologic care, not an afterthought, could improve outcomes and comfort for countless patients. The real danger lies not just in losing weight, but in losing the chance to act before the body's decline becomes irreversible.